Hello, and thank you for joining me for the Mentor Program Clinical Pre-Lab on the lower quarter. Course objectives are as follows. Participants will be able to identify current literature regarding physical therapy diagnosis and interventions for lower quarter dysfunction. Participants will be able to utilize diagnostic values for clinical decisions, and participants will be able to identify key biomechanical and anatomical components in the diagnosis and treatment of lower quarter dysfunction. When we think of the hip, we know that the hip is a very stable joint, surrounded by multiple ligaments, multiple muscles, and a lot of these muscles are very powerful muscles. We do know that distraction of the hip joint will reset it and decrease hypertonicity of the muscles that surround the hip. We know that compression will facilitate muscle tone. Key deep stabilizers of the hip, which happen to be on opposing sides, are the pectineus and the quadratus femoris. Tonic muscles of the hip that will lock it up and prevent motion and mobility, the iliopsoas. So if we remember back to our lumbar discussion, if we have lumbar dysfunction, we know that the iliopsoas attaches from the lumbar spine to the anterior hip, so we need to make sure that we're clearing the lumbar spine. Quadratus femoris, we'll see in just a moment in a diagram how the quadratus femoris is horizontal to the hip joint, and that is why it can prevent so much motion in the hip joint if it is dysfunctional. The piriformis, I think we're all very familiar with, as well as the pectineus, which is often a muscle that tends to not be looked at quite as often, especially with gluteal buttock kind of piriformis types symptoms. We do know that mobilization will stimulate the proprioceptors of that joint and will inhibit the deep stabilizer muscles. So again, as I just briefly mentioned, if we take a look over on the left diagram, we can see the quadratus femoris and its horizontal orientation to the femur. We can also look at the piriformis and how it has a downward angling towards the greater trochanter of the femur. Often when we're palpating for the piriformis, we tend to be too low, and we're actually palpating more of the quadratus femoris versus the piriformis. So palpation skill is extremely important, but both muscles are very, very common in hip dysfunction. If we move over to the right diagram, we can certainly see the pectineus, where it's coming off the pubis and attaching to the femur. Again, what we tend to see is that if the piriformis is lit up, or even any of the posterior gluteal, deep gluteal muscles, superior inferior gemelli, quadratus femoris, piriformis are hypertonic, the pectineus will often always be very hypertonic and sensitive as well. So another area to go in and make sure that we address. And of course you can see where the iliacus and the psoas form the iliopsoas attached both in the lumbar spine and the anterior component of the hip. Just a real quick review of hip functional strategies, which can certainly help in your treatment of the pelvic girdle and the hip joint. In the frontal plane, we have an example of how the left gluteus medius, the left adductors, and the right quadratus lumborum act together in synergy to prevent pelvic drop. So if we've moved our patient from supine to side-lying hip abduction exercises, we've improved their strength, we've improved the length-tension relationship of the muscles and making sure that there are no joint dysfunctions preventing or inhibiting muscle contraction. We move them up into standing. So now we have them standing on their left lower extremity. We are firing the left gluteus medius, the left adductors, and the right quadratus lumborum while we're performing right hip abduction. So a lot is going on in that, and so if we're seeing pelvic drop during that activity, we know we need to address somewhere one or all of these muscles. Within the sagittal plane, the gluteus maximus and hamstrings, they will contract at different phases of gait, often decelerating the lower extremity before foot strike. Within the transverse plane, the gluteus maximus and deep external hip rotators will slow internal rotation of the femur and the tibia to control pronation. And we'll go into this more in depth as we go through the presentation. So we want to look at a quick study looking at comparing manual therapy and exercise uh, in hip osteoarthritis by Hoeksema and al. So the purpose was to determine the effectiveness of a manual therapy program compared to an exercise-based program with individuals in hip OA. Measurements were performed at baseline, after the 5-week treatment period, 3 months, and again at 6 months post-op. Patients were treated 2 times a week for a total of 9 sessions over a 5-week period. The manual therapy group included manual stretching, traction of the hip, and traction manipulation of the hip, as well as interventions to the lumbar spine as needed. The exercise group was they had very specific exercises that addressed individual symptoms and were adjusted based on what the presentation was like. They did an outcome assessment, was a 6-point Likert scale, was the primary outcome, and then the Harris Hip score was the secondary outcome. The results demonstrated success rates in both groups. In the primary outcome, which was the Likert scale, within the manual therapy group, there's an 81% improvement or reported improvement, and in the exercise group there's a 50% improvement, and these were both at 5 weeks. Patients in the manual therapy group had significantly better outcomes in pain, stiffness, hip function, and range of motion reported, and the effects of manual therapy endured at this 6-month follow-up. So what's our takeaway? Manual therapy in hip OA is more effective than therapeutic exercise alone. Obviously, if we're combining these two, we can extrapolate that our patients are even getting more benefits and more statistically significant improvement in their mobility. As we move down the kinetic chain, the knee is often the middle stepchild due to foot and hip dysfunction, since it's in the middle. So as we move through the knee joint, again, there's kind of an algorithm that we would want to look at if we're evaluating the knee joint. We need to look at the patellofemoral joint, the tibiofemoral joint, the proximal tibiofibular joint, the distal tibiofibular joint, talocrural, and lastly the sacroiliac joint. With regards to the patellofemoral joint, it should be the first joint that we look at if the patient has any complaints of knee flexion limitation. A couple of keys with regards to the tibiofemoral joint. If a patient complains of a posterior pinch type pain during knee flexion, think of meniscus. Perhaps the meniscus is not gliding correctly, and then it's getting pinched between the tibia and the femur. If we have an anterior pulling type of pain, you immediately should go, during knee flexion, you should immediately go to the patellofemoral joint, assess the patella, assess all the soft tissue structures around the patella. With regards to the proximal tibiofibular joint, this can refer pain to the lateral knee joint. It can mimic IT band syndrome. So again, if the proximal tib fib is either stuck anteriorly or posteriorly or does not have the correct movement, it can certainly create lateral knee pain. With regards to the distal tib fib joint, we know that hypomobility here will cause limited ankle dorsiflexion. This is often seen with ankle sprains, is that the distal tib fib is stuck anteriorly, and so we must address that. If we're limited in our dorsiflexion mobility, this is often going to cause increased rotational forces throughout the tibia and the femur, because the foot is going to overpronate to compensate for that. Again, with regards to the talocrural joint, if there are restrictions here, again, it will cause increased internal rotation and rotational forces through the tibia. And in the case of the knee, it's going to create a more transverse type symptoms at the patellofemoral joint, in particular patellar ligament. Sacroiliac joint we discussed in the lumbar spine component, but if we've got anterior or posterior iliac rotations, this can affect the length tension relationship of the quadriceps and the hamstrings, affecting strength and range of motion. Some specifics on patellofemoral joint dysfunction. If we have limits to inferior patellar mobility, there's a couple of things that we need to address. Segmental clearing, we've got to go and look at the quadriceps. Is the quadriceps hypertonic because L4 has a dysfunction? So go up and clear L4. The articulus genu can be hypertonic. It is a feed-forward muscle. This is very similar to what the transverse abdominal muscles do. When the brain sends messages to the body that say, hey, we need to bend our knee, the articularis genu fires immediately to pull the fat pad out of the way so that there's not compression during knee flexion. Suprapatellar pouch. When that patient that comes in that's post-surgical and they complain of a band across the top of the knee just superior to the patella, immediately go there and check out the suprapatellar pouch. You'll often feel a lot of grittiness and discomfort and tenderness to palpation. If we can improve that mobility, again, it often will improve the patellofemoral mobility, allowing it to glide inferiorly to help with knee flexion range of motion. So real quick, kind of an inferior cocktail treatment, if you will, with patellofemoral. Inferior patellofemoral glides, suprapatellar pouch cross friction, and articularis genu strumming. These can all assist with limits to inferior patellar mobility and patellofemoral dysfunction. With lateral tracking, we need to look at the IT band and the lateral retinaculum, which we know will hold that patella more laterally. Again, we've talked about components with ilial rotations. If the ilium is rotated anteriorly, we will see increased tension on the posterior attachment of the glute max at the TFL, affecting the mobility of the IT band, as well as if it's posteriorly rotated, the anterior portion of the TFL is lengthened. So we will again see alterations to the IT band mobility. Foot overpronation. Again, if the foot is overpronating, the lower extremity at the tibia and the femur, we get increased rotation here, creating increased stress on the patella and the patellar ligament. Surgically, we may see the inferior infrapatellar contraction syndrome. It's often after arthroscopic knee surgery. What we'll see is there's portal puckering of the surgical sites. The outer rims are elevated, but the center of the incision is depressed in. There's posterior scarring of the fat pad, and during end range knee extension, the fat pad does not move anteriorly enough, and you often will see an anterior type pinch pain with these patients. So if we're seeing this type of puckering and anterior knee pain or anterior pinch pain, especially after arthroscopic meniscus surgery, repair, or meniscectomy, look at those portal sites and get in there and work the scar tissue. So a key takeaway at the knee joint, if you really are if you're able to address these three components, you often will find that you'll fix most hip and knee dysfunction. Hip external rotation weakness. And the key is to find out why are the external rotators weak. It is not just to strengthen them, because we know if they're inhibited, we can strengthen all day long and we're not going to make any changes. But with the weakness, we tend to see that internal rotation of the femur, internal rotation of the tibia, and overpronation. If we're looking at a functional squat, if the knees are going in, it's hip internal rotation, it's not valgus at the knee. So you've got to look at the hip external rotators. So, and again, one of the things that we often learn in school is when we do squats is to put a small bowl, towel roll, bolster, whatever, between the knees to help with that posture. So what are we doing? We're actually firing not only the quadriceps, but we're firing our adductors, which are tremendously powerful muscles and are going to continue to facilitate adduction and internal rotation of the femur. What is much more functional is to do an exercise band around the knees, have the patient actively perform external rotation while they're performing a squat. Much more functional and will improve the hip strength much better. If we address overpronation, again, we've got to figure out why is the foot overpronating. Is it joint mobility dysfunctions at the great toe, the distal tib fib, the talocrural joint? Is it muscle inhibition at the sacrum because there's a sacral torsion or an iliorotation? Again, we've got to find out why is there overpronation. And then again, we need to look at L4 and L5 segmental clearing that could be creating quadriceps or hamstring hypo or hypertonicity. Looking at some studies, Deal and al. looked at knee-OA with supervised exercise and manual therapy versus a home exercise program alone. The purpose was to compare the outcomes between those two, basically the home exercise program and the clinic-based program. They looked at 134 subjects, and they were either randomly assigned to the clinic group or the home exercise program group. The primary outcome was the WOMAC. Secondary outcomes looked at 6-minute walk test, frequency of knee injections or surgery, and medication use. The clinic group attended 8 therapy sessions. It involved manual therapy that was individualized based on the presentation and included passive and accessory mobilizations. There's manual therapy to the lumbar spine, hip, and ankle as needed. There was a standardized exercise program that included active range of motion, muscle strengthening, muscle stretching, and cardiovascular training. The home exercise program group performed the similar exercise program that the clinical group did, including the active range of motion, the muscle strengthening, stretching, and cardiovascular exercise. There was a follow-up exam at 2 weeks for the home exercise program group to make sure there were no adverse effects. At 4 weeks, both groups returned to the clinic, and the WOMAC and the 6-minute walk test were performed again, and both were blinded. So the results of the group demonstrated that both groups did improve, but there was noted significant reductions in the WOMAC scores and improvement in 6-minute walk test distances over 4 weeks. The clinic group was markedly better in WOMAC scores at 4 weeks and 8 weeks, and the clinic group also demonstrated increased satisfaction and decreased medication group. They did note that at 1 year, both groups were equal, but they felt that this was primarily due to performing the same home exercise program. Currier and al. looked at developing a CPR to identify patients with knee pain and clinical evidence of knee OA who would respond favorably to hip joint mobilization. So the purpose was to develop that clinical predictor rule. And they also wanted to look at the predictive validity of individual clinical tests for identifying these types of patients. There were 60 subjects. They completed self-report questionnaires, which included the numeric pain rating scale, the WOMAC, the patient-specific functional scale, or the PSFS, and the GROC, or the Global Rating of Change scale. There was a clinical examination of the hip and knee. There was functional tests that were performed, which included a squat test and sit to stand. And then they were treated with 4 hip mobilizations. There was follow-up testing performed 2 days later. The hip mobilizations were a caudal glide, AP glide, a PA glide, and a PA glide with flexion, abduction, and external rotation. Each mobilization was performed 3 sets for 30 seconds at grade 4 with a 30-second rest between sets. After data analysis, the CPR developed contained 5 variables, and they were hip and groin pain or paresthesia, anterior thigh pain, passive knee flexion less than 122 degrees, passive internal rotation of the hip less than 17 degrees, and pain with hip distraction. So at follow-up, 41 subjects had favorable outcomes to the hip mobilization, and if they found that if 2 variables were present, the likelihood ratio was 12.9, with a probability to succeed at 48 hours of 97%. So the results suggest that the CPR developed could improve the decision-making process in patients with knee osteoarthritis. So as we continue to move down the kinetic chain, we hit the foot and ankle. A quick biomechanic and anatomy review. The distal tib fib joint, during dorsiflexion, you get a posterior and superior glide. The talocrural joint, during dorsiflexion, we should see a posterior glide, and at the first MTP, we should see an anterior glide during extension. Plantar fascia or heel pain, couple of key points to keep in mind. Cuboid dysfunction. If the cuboid is plantar flexed, it'll alter the mechanics of the peroneus longus. This will inhibit the muscle and decrease its stabilization component to the medial column of the foot. A lot of times we'll see this as a secondary component of heel pain because they're walking on the lateral border of their foot because the medial heel hurts. So again, it's one of those compensatory pillars that we need to treat and assess. Dysfunction of the tibialis posterior and anterior. Again, we need to figure out why this is occurring. Perhaps it's lumbar or pelvic girdle dysfunction, but both are responsible for decelerating pronation. That is their function. And if they're dysfunctional, that pronation is going to be too much or it's going to occur too fast. Orthotics are designed to decrease the amount and or the speed of pronation. It's really what I've found in clinical practice is a component of treating any type of lower extremity joint dysfunction, whether hip, knee, or foot, ankle. It is not an let's give them orthotics and let them walk out the door. It's something that will help put the foot in a better position, but we need to address any of the joint dysfunctions throughout the lumbar spine and lower quarter. With regards to the foot and ankle and stabilization of the arch, we talked briefly about the peroneus longus. It plantar flexes the first ray and it increases the medial arch. Tibialis posterior and longus form a force couple that compress the tarsal bones and stabilize the arch. And the windlass effect. The dorsiflexion of the great toe increases tension of the medial band of the plantar fascia and medial column of the foot, hence stabilizing the arch. A lot of folks we see will have valgus of the great toe, or will have extreme limitations to great toe dorsiflexion. If that toe is not dorsiflexing correctly, you lose the windlass effect, but also your body's way to compensate is to overpronate. So one of the things you can look for if you're suspecting joint mechanic dysfunction or limited toe mobility with foot and ankle problems or heel problems in particular is look for calluses along the lateral border of the first MTP and the DIP of the great toe. They'll often have calluses there. As we've mentioned, not only with foot, ankle, but knee and hip, we've got to find the cause of overpronation. That internal rotation of the tibia will cause adduction and internal rotation of the femur. Works all the way up the chain. And we briefly mentioned this overpronation places transverse stress on the Achilles tendon and the patellar ligament, which creates excessive stress and tissue damage and pain. We know that these tendons really prefer to work in the sagittal plane, not the transverse plane. So one of the key things, how do we tell if it's hip external weakness versus overpronation of the foot? Well, we can achieve this through a single leg stance test. You're looking for compensation at the pelvis, if it's the pelvis, and hip external rotation weakness. If it's just the foot, you're going to see a lot of movement and compensation at the foot, and the pelvis is going to stay level. So, with single leg stance, if we're seeing rotation of the lower extremity, is it the foot or is it the hip? If the foot is producing all of the movement, then you can pretty much bet that it's overpronation that is the problem. If the pelvis is not staying quiet during single leg stance and the rotation, you're going to see hip external rotation weakness in the transverse plane, and you'll see glute medius weakness in the frontal plane. So anytime you're dealing with lower quarter dysfunctions, always really good to do a single leg stance, super fast, easy to do, and you'll get a lot of information and know exactly where you need to hit during your evaluation or your treatment based on what the body is doing during single leg stance. So a couple things with plantar heel pain. Cleland et al. Looked at manual therapy and exercise versus electrophysical agents and exercise in the management of plantar heel pain. And so the objective was to compare the effectiveness of these two treatment approaches. There was a standard examination. They completed the LEFS, foot and ankle ability measure, and the numeric pain rating scale. They were randomly assigned to a manual therapy and exercise group or the electrophysical agents and exercise group. Treatment consisted of 2 times a week times 2 weeks, followed by 1 time a week for 2 weeks. The manual therapy group received aggressive soft tissue mobilization to the calf and plantar fascia, rear foot eversion mobilization, thrust and non-thrust techniques to the foot and ankle, and they addressed any limitation in adjacent areas. They performed exercise mobility exercises and had a home exercise program. The electrophysical agents group with exercise. The electrical physical agent components were ultrasound at 1.5 watts per cubic centimeters at 100 hertz, 20% for 5 minutes to the plantar fascia. It was followed by iontophoresis with dexamethasone at 40 milliamps per minute. And then they performed the same exercise mobility exercises and home exercise program that the manual therapy and exercise group did. So results of the study, both groups demonstrated improvements. However, the manual therapy and exercise group provided greater benefits in the short term with regards to functional mobility that was compared to the electrophysical agent group and exercise group that was noted by the LEFS. The LEFS surpassed the MCID, and that was maintained at 6 months follow-up. Pain and the foot and ankle ability measure scores were also statistically significant with the manual therapy and exercise group. Another study of the foot and ankle looked at short-term response to thrust and non-thrust manipulation in post-inversion ankle sprains. And this is by Whitman et al. The objective was to develop a CPR to identify patients who had inversion ankle sprains and would likely benefit from manual therapy and exercise. So there's a standard examination. There were self-reported measures. Again, we looked at the numeric pain rating scale, foot and ankle ability measure, the LEFS. They did passive and accessory motion to the proximal and distal tib fib joints. They did looked at talocrural, subtalar joints, and they were noted as either being hypo, normal, or hypermobile. They did manual muscle tests to the lower extremity, as well as a navicular drop test. Treatment was standardized over 2 treatment sessions. The program consisted of 4 components. There's ankle, foot, thrust, and non-thrust manipulation, general mobility exercises, patient education and activity tolerance, and ice and elevation. So the first treatment was described just as what I just described. They came in for treatment session number 2. They would complete the global rating of change score, and if it was +5 or better, it was deemed that the treatment was successful and the study participation discontinued. Those that did not achieve that score received the exact same treatment as the initial treatment on day 1. On treatment 3, those patients completed the global rating of change score again and scored as above. If the patient did not achieve the score, they were categorized as non-successful and the involvement in the study ended. If they did score higher, they were deemed a successful outcome. They did determine that there were predictor variables, and 3 of 4 of these, if they were present, there was a likelihood ratio of 5.5. These were symptoms that were worse with standing, symptoms worse in the evening, a navicular drop greater than or equal to 5 millimeters, and distal tib fib hypomobility. Rapid treatment improvement in inversion ankle sprains was determined to be an important clinical decision-making process. The results of the study demonstrated that 75% of patients are likely to experience a successful outcome with the manual therapy and exercise program described in this study. So in summary, again, we've got to utilize the best evidence that's available to us. We need to classify our patients if at all possible. We need to look at all areas that could possibly be affecting our area of pain. And so again, we go back to our treatment pillars and assessment of muscle, joint, fascia, and compensation. If we've cleared all these areas, we have a very high success rate of getting our patients better. Thank you.